So our next presentation, nothing sweet, right? Our next presentation is by Olga and she'll talk about cognitive function in Medicare beneficiaries.
It's really wonderful to be back. I'm going to just double check and see if this. The project that I'm presenting today is part of a National Institute on Aging R33 infrastructure project. The co-PI on this is Hai-Chun Lin. She was previously at Yale before coming to Rutgers University, and she's got a lot of expertise in longitudinal trajectory modeling and irregularly spaced, working with irregularly spaced data, which is really essential to what we've been doing. And we'll be showing you. Actually, let me give a little bit more credit to our team. So next to her is Hawaii, who is a PhD student, has been just absolutely critical in basically rewriting some software that made this project possible, the trajectory work I'm going to show you today. Fred Kovalar is geriatrician. It's part of our team. Adam Zafar, brilliant data scientist that's does all the linkage and harmonization of data with me, and phenomenal programmer. Dawn Kim is a research assistant professor who's been working with my lab, who's also been tremendous. She's got a lot of background in end-of-life care and health policy. Maria Lopez coordinates everything, and Jason Roy, biostatistician, who many of you probably have heard of. All right. So this project, the first game that I lead is looking at harmonizing and merging different data sets to understand change over time in care setting, geriatric syndromes, including cognitive impairment, change in physical function, and shared risk factors. In AIM2, where Hai-Chun Lin is leading this to develop some new analytic methods to identify patterns of aging trajectories experienced by older adults in their last years of life, and the association of those trajectories with shared risk factors and physical outcomes. And the third aim, which we'll come back to at the very end, is doing some more complex, multi-level and interactive modeling, including with artificial intelligence and machine learning models. So this is the conceptual framework for our grant, just to give a little bit of the big picture. We're looking at multi-level factors from patient through society, and considering the biological, behavioral, physical, and sociocultural environments. All right, so a little bit of background. What I'm presenting to you today is on cognitive trajectories in late life. So we're specifically looking at the last 5 years. There's been a lot of work on this topic by other groups that's, including systematic review that was really nice kind of summary of 30 studies. It's interesting, some of those studies were exclusive to white men and others. So it's interesting to see the breadth of the work that's been done on this topic, many with relatively small sample sizes, whether that came from longitudinal studies like HRS, which that's a lot of data to some people, and with national Medicare data, it's also relatively small. So a lot of these studies found 3, 4, 5 different kind of trajectories of aging. So the no decline, mild decline, moderate decline, and accelerated decline, and sometimes that's they're described a little bit differently. But so in this study, we did a retrospective cohort of everyone who was enrolled in Medicare that died in 2019, and set the criteria that they be continuously enrolled for 5 years. This was to ensure that they had the ability to have information contributed for each of the 5 years. So if they were only in Medicare 1 or 2 years, I wouldn't know necessarily if they'd been diagnosed or had cognitive impairment while they were on a different type of insurance. So we combined, it's really terrific that, you introduced a lot of this, and a lot of the other states they have as well. We use both Medicare and Medicaid fee-for-service and the encounter for the Medicare Advantage or the data that's available, as well as post-acute and long-term care assessment data. So like Yolanda Barone was talking about the OASIS data, and the MDS data that you've heard about, all of these contribute to the cognitive function trajectories that we developed in this project. So our main outcome was a 4-category cognitive function indicator, and this is preliminary work. So we kept it at these 4 categories. You can always go and try and do more detailed work. So in the future, but this is where we're starting. So no impairment, memory loss, mild cognitive impairment, and then the highest category being dementia or severe impairment, severe cognitive impairment. Right, and the modeling was done with group-based trajectory modeling. So I want to take a second to talk about how we looked at the race ethnicity of the Medicare beneficiary population. There are some limitations with the administrative race ethnicity data. And in our projects, we augment that data with self-reported race ethnicity data from post-acute and long-term care settings that's available on 75% of everyone that's died in Medicare. So we're fairly confident that we're getting much better classification of people who are self-identify as Asian Pacific Islander, Hispanic, or American Indian, Alaska Native. Okay. So again, let's see how our sample came down. The largest exclusion group were people that weren't continuously enrolled for 5 years. Again, in the future, we can do more work with that group, but this is just the first steps. Restricted to people that lived in the United States or Puerto Rico, and I think US Virgin Islands also in the group. And we wanted to make sure that everyone was at least 50 years old by the time they died. Although, and for this project, we dropped the people who were race and ethnicity was unknown. So that's a relatively small number in this 6,000 out of 2.3 million. All right, we did the group-based trajectory modeling. We started out doing it on a 10% sample. And when we got a pretty good fit with the model, we replicated it and then expanded it, we took a new seed, split our sample population into 10 pieces and reran it on each of the 10 pieces. So let's see. All right, Hai-Chun Lin is really the one to talk to about the statistical model. I'll give you a second to the shape of the trajectories for each class. Were modeled using proportional odds for the ordinal categories of the cognitive function variable. And then each beneficiary was assigned to one of the trajectory classes, which they had a higher posterior probability. So we estimated the group-based trajectory model for 2 through 12 trajectory classes, selected the one with the best fit based on the BIC value, and that was the 10-class solution. All right, and then I was starting to say we replicated this work on the 10 different samples and got very consistent results. All right, overview of the study population. Take let your eye hit the numbers of the groups by racial and ethnic category. So, and what I'm showing you today, this is 90% of everyone we have available. So I'm still holding back another 10%. But we have almost 9,000 American people are self-identified or were classified as American Indian, Alaska Native. So pretty large numbers. And then the other number to catch is the number that had a diagnosis of dementia in the data set. So that was 47.6% had a diagnosis of dementia reported in their Medicare record by the time they died. So there may be more people that had dementia but didn't have a diagnosis, but this is the number with the diagnosis. So these are the 10 cognitive function trajectories. So like I said, we did this, ran these models 10 different times and got virtually the same exact you couldn't really tell the difference between when I set all 9 of them side by side. The only place that they differed in any of the 9 was 5 years before death. There was a little change in these two crossed in one and didn't cross in another. But it was, and the other thing that was the same across, there's, essentially 10 groups that we ran this on, is the proportion of people that fell into each of the 10 classes. So again, there is a little bit difference, 1 or 2 percentage points across the 10 different times that we ran this, but very consistent results to the extent that, I feel very comfortable that we brought all of this together. So we have for each person, we have in their, analytic file assigned them to one of these 10 classes based on how they actually ran. So it's not, sometimes you can do that through predicting which one they would be part of, but we did it off the actual runs. Okay, what else is interesting here? Okay, so these, thinking about some of the prior work, groups have often said like there's 4 main trajectories of cognitive decline. So we have 10, and some of them know that the slope's kind of similar. So H, F, and I, these kind of all have that same chart. So maybe someone might look at that and say, well, these are all kind of the same phenomenon. But given how long, the difference in time before death, how long someone was living with severe impairment, I think it makes sense to leave it like this for now. So we're going to focus for pretty much the rest of the talk on 2 of the classes. So the one with the purple circle that has a D in it, and we're going to call that dementia, with a 4-year, they have at least 4 years of severe impairment. And the one in the bottom right with the B, the green circle, and that's like our baseline or people that have intact cognition all the way through till death. What would be there? So looking at the variation in racial and ethnic composition of these different cognitive trajectory classes, the yellow highlighted cells help you to start to pick out some differences. So you can see that Black race is more, could say, overrepresented in 4 of the groups. One of these being the group with the longer, 4 years or more with severe impairment, cognitive impairment, and this group is also has higher proportion of Asian American, Pacific Islander, and Hispanic individuals in that group. So these are column percents, and I'm going to switch now to row percents. So we get this, the yellow stars are kind of matching up with the yellow cells that were highlighted before. So you get the same picture of things that were kind of standing out. And this is unadjusted. This is just descriptive for right now, but this is a good starting place to explore the data. So, all right, so this is the kind of row percent. And I want to take it a little bit farther and look at sex differences. So the patterns between females and males, very similar, but there's a shift. So males are much more likely to be in a group, like across all racial and ethnic groups, that have the intact cognition all the way through to death. And females more likely to be the one with the longer cognitive impairment at a severe level, or classified as dementia for at least 4 years. And there's lots of literature on that. This is nothing new, but this was something we're easily able to pick up in this analytic file. All right, so keeping the focus on these 2 trajectories, this is logistic regression models predicting these 2 trajectories. So this is 2 separate, distinct logistic regression models. One with the baseline or the intact cognitive trajectory, and the other with the dementia for 4 years or more trajectory. And you can see there's, it's kind of box here is highlighting some racial and ethnic differences, older age is a strong predictor, female sex is a predictor, and there's also a few comorbidities that are starting to pop out. So depression, cancer, stroke or TIA, and heart disease, heart failure, history of having a heart attack, hypertension and hyperlipidemia are also going to show up in a second. So we reran this. I'm going to show it to you for the trajectory model separately. So this first one is the D class, the one where it's 4 years or more with dementia or severe impairment. So it ran separate logistic regression models just within each racial and ethnic group separately. So here again, you see older age is strongly associated with as a predictor of the having dementia for 4 or more years. And there's a lot of spread across racial and ethnic groups in that. The others are a little bit more consistent. And there's a couple of things that are going to pop out a little bit later that are of interest. So one of these, this cluster here is depression, okay? So across racial and ethnic groups, depression was associated with that longer period of time having dementia. And, again, this is a new finding, but there's, this is just one study that, from the recent literature, Medina's cohort. And we have lots of research in the US that also is similar. Okay. So this is another one looking at the difference in logistic models stratified by race and ethnicity, predicting the baseline or the cognitively impact trajectory. And here, there you see slight variation across the dots for the racial and ethnic groups, but they, are definitely showing a similar pattern. And there's just a couple spots here where there's some interesting things where they kind of cross the line. So one here is hypertension and hyperlipidemia. You see like Hispanic is on the opposite side of the one compared to some of the other racial and ethnic groups. All right. So in this one is the cancer cluster. So we heard lots earlier today about, forgive me, I've forgotten your name, but I know you had some research on cancer. You were talking about it earlier, and this has popped up in a couple of presentations. So there's this inverse relationship between cancer and dementia. So here, cancer is predicting not having dementia. And at first I was looking at this, I'm like, is this right? And then I went to the literature and everybody's studied this, or many people have. So there's tons of literature on this topic, including some great work by Maria Glyndemore and colleagues, who have been published in JAMA. So, I just want to kind of the takeaways from today is we were, successfully able to harmonize the claims and the assessment data tell a much more complete story than if we were only looking at one alone, and construct this analytic data set that describes cognitive function trajectories over the last 5 years of life. Using a group-based projection modeling, we found 5 distinct cognitive function trajectories that are reproducible and consistent across 10 independent 10% samples. Age, sex, race, ethnicity, chronic conditions, are strong predictors of cognitive function trajectories. This is consistent with the literature. And really, this is proof of concept. So this is replication and validation of key findings from longitudinal panel studies like the Health and Retirement Survey and clinical cohort studies like a lot of the Alzheimer's disease centers are running. So there's lots of opportunity this morning. Just kind of take us back to the welcome and introductions. Dennis Tolley and Rima Pedorado, if I mispronounced that, we're kind of setting the tone for the day and thinking about how wouldn't it be great if we could really be able to leverage and work back and forth with some of these very large data sets, population health data sets, and some of the more granular clinical detailed studies that So to be able to kind of work with each other and tell a bigger story and better understand the data. I mean, this is really fine for, cross-country comparative work. You're working on a small cohort study with 2,000 people and you see something that seems interesting to be able to say, oh, maybe we can test this in, the whole national Medicare data and see if you're able to find a similar association between something that you think might have potential. So lots of opportunity here. This project we anticipate it's going to have 3 full years left. So the next year, we're taking a no-cost extension to really spend a little bit of time in building out relationships with collaborators. So if you'd like to work with us, this is a great time to reach out. And then in the next 2 years after that, we'll be hoping to have this data set and methods really available for all kinds of collaborative projects and eventually have this be self-sustaining. So if you want to, think about some pilot work, write an R01 or another type of project using the infrastructure, the resources, the methods we've developed, the analytic files, this is where we're going. All right, so thank you.
To finish up, I'd like to walk back towards the topic of disparities. So we talked a lot about Alzheimer's disease and related dementia. Talked a little bit about the systems of data that generate our ability to do some of this research. But one of the things that we lost out is some general comments on the applicability of all of this when the concepts of disparity research. So one of the things we look at, especially when we look at problems with racial and ethnic disparities, is problems with self-reported variables. And we see this demonstrated here. So a lot of the self-reported variables available to the CMS are a legacy of old policy decisions. When we go all the way back, there was only 3 races, white, black, and other. And if you go far enough back, that's all there is. You're white or black or you're other. Then there was a period of time when they were trying to decide, do we want Hispanics on the list? Or do we not want Hispanics on the list? If we want them on the list, how do we want them on the list? Just went on and on and on. This is a problem we're inheriting as researchers right now. But the solutions are also here. So there's a lack of representability of minority populations in clinical studies. Well, they're not underrepresented in the Medicare program. They're right there. If you can figure out a correct algorithm to answer your research question, for which you don't have a sufficient population in a clinical study or a survey like the HRS, well, the entire older adult population is arguably right here. All you need to do is be able to get it and know what you're getting with all the limitations involved. So again, the racial variable isn't that good, especially for Hispanics and so on. But we have just introduced over 3 years of this workshop, different methods that can be used to tease out your social cultural background. And we call them social determinants of health now. Back in the day, it was socioeconomic, sociocultural environment. What's a Black woman from Louisiana at the end of the day, right? It's her cultural environment. It's not her skin color so much as where did she grow up? How did the people around her talk? How was she treated? Right, et cetera, et cetera, et cetera. None of this is going to be on a questionnaire. You have to tease it out, whether doing it by Latin structure analysis, Latin class analysis, just slap some factors on it. There's ways of getting around the problem. And the good thing about this system around the Centers for Medicare and Medicaid Services is that it's a system that's working right now. So any structural discrimination that may be present, it's going to be visible in the workings of the system. It is a system, and everything that happens to it is a systematic event. And it's a linkable system. So if the Medicare records aren't good enough for you, you have the MDS, which can be linked in. You have death records, which can be linked in. You have studies, which can be linked in. And they're getting better and better every year. So if there's a will, there's a way, and we're here to try to help you with the way. And right now, if you have posters, it's a great time to go out and be present next to your posters.
Excuse me.
Yes.
There's some questions there.
There are questions.
We will have some questions to present.
Questions to present as well. We have 7 minutes before the Alzheimer's disease sponsored reception. So no hurry whatsoever. Questions to the presenters? Igor, do you have a question? I saw a hand.
Very interesting work you're doing. I missed it, but how did you measure cognitive impairment with fee-for-service data? Like, I mean,
Sure. So we used a mix. So we took ICD-9 and 10 codes for the claims. We got information on memory loss, the diagnosis, memory loss, mild cognitive impairment diagnosis, and then all the other things that we associate with Alzheimer's disease and related dementias went into that third category of dementia. And then using the post-acute and long-term care assessment data, there's also a set of items, BIM score, and some other items that we were also able to identify additional people that had memory loss, but not worse, or mild cognitive impairment or a more severe impairment that we also mapped.
so people who use nursing homes or home health
Right, or inpatient rehab.
or inpatient.
Some details here. So the MDS, or the long-term care minimum data set, comes in 2 versions. It comes in version 2.0 and 3.0, which is the current version. Starting with 3.0, which I think maybe in 2000 something, I think is pretty
So the fiscal year 11.
Mhm.
So from
You
October
know better than me. They introduced a brief interview for mental status or cognitive status, the DIMS, right? So before that, they didn't have that, but there's 2 index-based measures of cognitive impairment that's derivable from MDS 2.0. That's the cognitive something or other scale.
Performance scale.
Cognitive function scale.
performance skill.
Oh, there you go. So you should be giving this speech. I know we go much
No, that's
better.
fine.
Right. So there's measures, but they're not very common. So they're not available in both the 2 and the 3, and you got to have some sort of crosswalk or way to map them over. Now, OASIS, the home health evaluations that people have mentioned, they're a little bit worse, because the MDS is generally for a nursing home environment, designed for a nursing home environment, and administered by a registered nurse. The OASIS questionnaire, at least those parts of it that I bothered to look at, are much, much simpler than that. And they require a lot less care to fill in. Are they worse or are they better? I don't know. They're definitely different. And if you don't have these secondary sources of data, so your only source of potential cognitive impairment is that ICD-9 based code. Well, we have an article by Igor based on the HRS where we've mapped the average tick score, which is available to the HRS, to your average individual with a given Alzheimer's disease-related dementia or a neurocognitive disorder claim. How accurate is that? The walkthrough as accurate as the physicians setting the diagnosis codes and the people doing the HRS survey. We trust them. At least that's what we say when we publish our papers. So there's a crosswalk that you can at least have a basic idea. You're just diagnosed with the 331. What do we expect you to have? Yeah.
So can I have a question to Sandra? So Arsenio, as a discussant, mentioned the importance of time trend. Yeah, in the comparison of medical advantage. So it's clear why, because new opportunities and so on. Which opportunity to measure this time trend in HATS? And did you try to?
Yes, to some degree. So in NHATS, it started in 2011. So we looked at the 2011 cohort and it's similar appearing. The latest cohorts, we don't have the Medicare linkage for them, so we're not able to examine past 2015. We can see that people change insurance status, and so there are the switchers. So the way that we defined it is what was their enrollment status at the month that they were surveyed in NHATS. Almost sort of like an intention to trade. So if they switched after that, we didn't consider them as having switched. We didn't consider it as like a time varying kind of exposure in our models, at least. From prior literature, we do see that the people that switch tend to be sicker. And so there does tend to be this, it's, for example, if someone develops more disability or develop new disabilities, at least in NHATS, it seems that they actually tend to switch back to traditional Medicare at some point. So we're not powered to examine those switchers because there's only about like 20 of them per month in the entire NHATS sample. So to some degree, we're able to explore that a little bit, but unfortunately 2015 is the last kind of national cohort that was kind of sampled purposefully to be able to represent the Medicare population for us to see.
Okay, thank you.
We have a question over here.
I have a question for you. So you mentioned that you found the inverse relationship between the having cancer and the severe cognitive impairment in the sample. So I'm trying to understand that. So maybe it is the survival bias, do you think? Because those who have cancer, depending on what type of cancer they have or at what age they develop the cancer, maybe they may not have the time to develop the cognitive impairment in the last 4 years of their sort of life. So
All those models were adjusted for all the comorbidities and age and sex. So there were, and I kind of thought maybe the same as you. So I think there's one hypothesis that's similar to that idea, but there's a ton of studies, and I just had 4 up on the slide. And one of them was like an editorial kind of summarizing some of the literature on the topic. So this is a well-known and documented phenomenon. So there's some thought that it's some of the things that make you more susceptible for cancer actually make you less susceptible for Alzheimer's disease through some of the pathways. And it's kind of interesting that that was also a finding on the Medicare Advantage. I think it was your slide, wasn't it? That we had lower rates of cancer and higher rates of dementia in the Medicare population. So it's kind of interesting. So some of these things, like they keep popping up and you look at it, it's like, is that right? Could that possibly be right? And then, realize that yes, in fact, there's 20 other people around the world that have found the same thing and have done a little bit more work. So yeah, it's a great question.
Yes.
Okay, so at your GSA presentation, you wanted to review statistical methods for your trajectories. So maybe backward, maybe in time, something like this. Do you have any progress in this? Do you have understanding how analysis figures appear?
So Hai-Chun Lin is leading the trajectory analysis work. So we've made a lot of progress since November, since you've heard us talking about some of this work at GSA, and hopefully we'll be presenting the next evolution of the work, at AAIC and GSA in the fall. You would hear more about it, but yeah, the work's progressing. We've had to rewrite a lot of the trajectory analysis software so we could use it in the CMS Virtual Research Data Center, and the machine learning work is progressing.
Okay.
Other questions? Yes.
Yeah, I just had one for Yulia. So the first thing I noticed about your slide was that it started in January of 2020, which was 2 months before the pandemic hit us.
Yeah.
And there were 3 things that we all learned immediately, which was that ethnic groups were suffering death more often. The nursing homes were experiencing death. Governor Cuomo, in fact, was under investigation for all of that. So my question, and Igor, I think, pressed the button today to submit a grant partially examining COVID-19. So my question is, how might that have biased your results, and what can we learn from that?
Yeah, due to the time constraint, I actually passed that slide, but yeah, I did mention that our study period from January 2020 to August 2022 exactly overlap with the COVID pandemic period, and we think that there is a limitation in the generalizability of our findings. But yeah, that was, and interestingly, I was in New York Manhattan when the pandemic happened. So yeah, but anyway, yeah, we admit that there is a study period, but that's why we want to further investigate for the other period and as well as the EMR data from other corporations.
Other questions for the speakers? MDS, Medicare Advantage, rails, etc. Well, we're 3 minutes late for the poster section, and the reception.
Reception from Alzheimer Association, yeah?